Good afternoon, everyone. Bonsoir. What else? Buonasera. Buenas noches. Buenas tardes. Masal al-khair, everyone all over the world. We are again very pleased to have you here in our 12th day of our webinar lectures on the liver imaging. Today is even more special day because we have Dr. Donald Mitchell. For me, when I first came 20 years ago to the United States, and I was doing body MR training in Mallinckrodt Institute of Radiology, which is a great institution, learning about MRI, one of the reasons was because of Don Mitchell. Every publication in the body MR, you find his name on it at this time. So people like me are really appreciative of what Dr. Mitchell did to the body MR and to the teaching of body MR. I have not told him that before, but I always appreciate the significant contribution of Don Mitchell to the literature of body MRI. I always think of him as the teacher, the professor, the mentor, and the gentleman. Dr. Donald Mitchell is a professor of radiology in Thomas Jefferson University. He's also director of the body MR and the chair of the Department Advisory Committee of the Department of Radiology in Thomas Jefferson University. Dr. Mitchell is a fellow of numerous societies, including the American College of Radiology, International Society of Magnetic Resonance Medicine, ISMRM, and SABI, which is formerly Society of Computed Body Tomography and MR. He had numerous leadership roles throughout his career. I mean, the time will not be sufficient to mention all of them, but to summarize, he was the ACR Chair Committee on Education, Body MRI, Course Director, Advanced Body MRI, and he was also, he had a leadership role in Akron Gynecologic Diseases Site Chair. He was the chair of RSNA MRI Refresher Course, and he was also the ISMRM, one of the board of trustees in ISMRM, and chair of educational program in ISMRM, and chair of workshop committee in ISMRM. He was also the chair of Society of MRI Technical Exhibits Committee, chair of Residency Training Committee, and he is definitely one of the very invaluable members of the steering committee of LI-RADS from 2009 to present. Well, he was one of the two sites where LI-RADS has started from, together with UCSD, with Claude Searle from UCSD. He was the chair of Management Working Group in LI-RADS from 2013 to 2017. He is a member of the working group. He's also a member of Hepatobiliary Contrast, Rad Bath Correlation, Evidence-Based, and Outreach Committee. Of course, Dr. Mitchell has numerous publications. He has more than 300 publications. And as I stated, if I keep introducing Dr. Mitchell, it won't be sufficient. The 1 hour will not be sufficient. So without further ado, I would like to ask Dr. Mitchell to start his talk, and we're all very pleased of having Dr. Mitchell. So Dr. Mitchell. Dr. Searle, do you want to say something about Dr. Mitchell, Don Mitchell? We have Claude Searle here, and I'm sure he may need to say something.
Khaled, I don't know what else I can add other than I agree with everything you've said. Don Mitchell is an amazing member of our team, and we're very, very proud and very, very honored and very pleased that he's been so involved with LI-RADS for all these years. And I could go on and on and on talking about how great Don Mitchell is, but no one wants to hear me talk, so I'm going to stop now and just pass the baton on to Dr. Mitchell.
Well, thank you, Claude and Khaled, for those very kind words. The honor is all mine to be part of this LI-RADS webinar, and thank all of you for tuning in to this talk as well as the previous talks, which have been outstanding. So yesterday we heard from Dr. Searle about the much about the clinical relevance of LI-RADS toward clinical management. And I'm going to extend on that today. This is a radiologist perspective, but taking into account what we can do to better inform clinicians as to how they can best manage their patients using LI-RADS criteria and categories to help them reach the best management decisions. So, in fact, I could retitle this talk. I've retitled it a few times, but from LI-RADS category to management decision. It's a route where we issue our report, but the purpose of the report is to help guide management, to improve management, and to improve the clarity of communications. So I'm going to, on this slide, outline where we're going to go over the next half hour. And the first thing I'll talk about was, why was LI-RADS created? There's a reason for that. To help simplify the relationship between LI-RADS categories and management decisions, I think it's good to make the list of management options finite, definable, and realize there aren't that many different options, that many different outcomes of the decision making. And once we realize how finite it is, this will simplify understanding how each category can lead in a few different directions. And indeed, then we'll talk about the categories and their management implications. I'll show some pre-treatment examples and then discuss briefly the difficult and challenging subject of making management decisions post-treatment. And finally, talk about one particular treatment, liver transplant, and the relationship between LI-RADS and a separate classification scheme that was created by UNOS, who's in charge of transplant allocation. So to begin with, why is there LI-RADS? Why did a large number of liver experts get together and meet repeatedly over several years to create the system of LI-RADS and then continue meeting to continue refining it? And it has been my honored opportunity to be part of this group, and I thank everyone else I've worked with in LI-RADS for teaching me much and allowing me to be part of such an important development. So why is there LI-RADS? Well, there is a great tendency in radiology to create standardized reporting systems, but they're not always worthwhile. Each reporting system can bring its own complexity. So the idea is only do this where it's really worthwhile. So when is it worthwhile? Well, number one, the disease should be treatable. If the disease isn't treatable, then that reduces the value of categorizing patients, because if there is no management, then there really are management options. So the other thing that's important, if we're going to have a standardized reporting system, especially one that involves categorizing disease states, there should be discrete diagnostic categories that have different management implications. And we realized right along that this was potentially the case with HCC, and the challenge was to come up with the best categories that would most help define these options. But this does not mean that treatment decisions follow directly from assigning a diagnostic category. So it's not a straight line, but rather sometimes a bit circuitous. There's additional information that has a big impact. So the important thing at the beginning is to analyze the imaging features using the very clear definitions that have been expressed in LI-RADS to recognize the diagnostic signs for a given observation and use them to assign a LI-RADS category. So the LI-RADS category is based on the imaging features. And the LI-RADS category relates to the probability of hepatocellular cancer or to other malignancies, but it isn't the sole determinant of that probability. So for example, if a patient has a LI-RADS 3 lesion, intermediate probability, but has an alpha-fetoprotein of 2000, it's probably hepatocellular cancer. So the eventual decision of what is the diagnostic probability takes into account more than the LI-RADS category, biomarkers, patient risk factors, etc. But this doesn't lead directly to a management decision. In fact, two different people, both of whom definitely have hepatocellular cancer, may indeed be managed differently. So there are important factors, comorbidities, patient preferences, and many other factors that the radiologist may have no awareness of. So we need to keep this in mind. We need to make sure that our report informs the thinking, but doesn't unnecessarily steer it in an uninformed direction. So as I mentioned, we're going to start now by discussing what are these options that we might end up with after assigning the LI-RADS categories. It's important that we keep in mind that this is not the general population we're dealing with. All of these patients are at risk for hepatocellular cancer. If they're not, we don't assign LI-RADS. And in fact, once they are at risk for hepatocellular cancer, the general recommendation really throughout the world, whenever it's achievable, is patients should be undergoing regular surveillance. They should initially be screened for cancer, but then undergo regular surveillance, which is generally recommended to be ultrasound every 6 months. So after assigning the LI-RADS category, perhaps the patient just returns to their regular surveillance if our interpretation of the diagnostic test is relatively indolent. So another option, taking it up one notch, instead of returning to routine surveillance, repeat the diagnostic imaging. So perhaps repeat an MRI or a CT in 6 months, or maybe even do it sooner, in particular if it's a large lesion that we might not want to wait a full 6 months if we're concerned that it might get out of control. Or we could repeat the diagnostic imaging, but using a different method. So for example, if the patient had CT, we'll perform MRI. Or if the patient had an MRI with an extracellular agent, maybe use an hepatocellular agent next time. Or maybe use contrast-enhanced ultrasound because of its superior temporal resolution and specific vascular enhancement. These are basically the 3 imaging options that we have. This essentially is it. Now that may not be enough, so anything more than that should go to multidisciplinary discussion to arrive at an individualized workup. So here there are many factors that need to be accounted for, which the radiologist often won't be aware of. Now, the outcome of this multidisciplinary discussion might indeed be options 1, 2, or 3 that we've just gone over. Or perhaps additional testing is needed, such as biomarkers. Or perhaps just go straight to treatment, but the discussion will help determine what is the best treatment for this patient. And then the other option is biopsy. And there are certainly many radiology reports that recommend biopsy, but I would caution not to do that. I've heard from many clinicians that they do not want to be compelled to perform an invasive procedure because they feel, rightly so, that them knowing the patient and taking into account all information should be determining whether or not there is a biopsy or other invasive procedure performed. Yet we don't want to pretend that biopsy doesn't exist. We would then be doing a disservice, because if indeed biopsy may be needed, we do want to communicate that. So sample phrases include options for further workup, include whatever else, and possibly biopsy. Biopsy may be necessary to distinguish between HCC and, let's say, cholangiocarcinoma. This is probably HCC, but to establish a definite diagnosis, biopsy may be considered. Because we do want to be able to bring this to the forefront of a clinician's attention, but not force their hand if they consider that this wouldn't be the best option. So now we'll proceed to a screenshot from the LI-RADS manual on management. So we've talked about the options, and now we're looking at each of the categories and a very brief description of what the options may be. So you see there's not a lot. There is still variability within each category, but not that much. So if there is no observation, the purpose of the diagnostic test was to determine whether the surveillance had an observation that should change things. But if the outcome of that is no observation, go back to surveillance. Similarly, for LI-RADS 1, it's essentially a benign normal study. Go back to surveillance. Now, if the diagnostic imaging was not sufficient to be able to categorize an observation, well, by definition, the diagnostic imaging was indicated in the first place. So we shouldn't just go back to surveillance because the diagnostic test was unsuccessful. Maybe we can repeat it and do a better job, or maybe we now realize that a different study would be better. Maybe the patient is moving too much for MRI, and maybe CT would be better. And if indeed they need the diagnostic test, but this particular diagnostic test wasn't successful, we probably don't want to wait the full 6 months. We probably want to repeat it sooner rather than later. So these things really make sense. When you think through any of these, there should be nothing that doesn't make sense here. Now, let's say you have a LI-RADS 2. It's almost, but not definite. It's most likely to be benign, but not certainty. For example, it's probably a hemangioma, but you're just not sure about it. There's a very good chance that you want to repeat the diagnostic test to see if it really still looks like that, and maybe you'd want to repeat it sooner. If your estimate of the probability of malignancy is more intermediate, then you may not want to wait 6 months, and you certainly wouldn't just want to go back to surveillance. You'd likely want to repeat the diagnostic test, or maybe do a different diagnostic test. And it may indeed be that in the radiologist's judgment, this is still an imaging problem that can be settled with repeat imaging. But once you think it's probably malignant, you really want to get a little more aggressive. Certainly, everyone who may be part of the management team should have an opportunity to weigh in. Are there surgical options? Should there be a biopsy? Interventional radiology? If there's a biopsy and that determines the diagnosis, then the discussion will be what's the best treatment. And notice that the cell for LI-RADS M is identical. Both of these indicate some uncertainty. Is it probably or definitely malignant? But even if it's definitely malignant, perhaps there's doubt as to whether it's hepatocellular cancer, cholangiocarcinoma, or even something else. So very often biopsy is applied to reach the diagnosis, as long as it's determined that there are different treatment options that would differ depending on the pathology diagnosis. And most often that is the case. Now we'll go back to LI-RADS 5. HCC confirmed. This is the diagnosis. We don't need additional imaging to make that diagnosis. We don't need biopsy to make that diagnosis. It's just multidisciplinary discussion to arrive at the best diagnosis. Now, some of these patients will get biopsied, but that would be for investigational purposes, perhaps a clinical trial, or perhaps for genetic markers, but again, not to make a diagnosis. And finally, all the way to the right of this slide, LI-RADS TIV, tumor in vein. Very often this will need to be biopsied, assuming that there are treatment options. So let's look at some examples here. So this is a slam dunk LI-RADS 5. It's got all the major features. It's got a lot of the ancillary features. We'll start at the top left with the T2 weighted image, moderately bright in the posterior right lobe, segment 7. And then we look at the T1 weighted images up top, in phase and out of phase. There's definitely fat in there. So we're quite confident it's a mass of hepatocellular origin. And look at the multinodular mosaic configuration. It's looking more and more like hepatocellular cancer, even before we look at the contrast enhanced images. So it's hypointense on the unenhanced T1. Nodular hyperenhancement, again with the mosaic configuration. A characteristic of hepatocellular cancer, as well as many other primary cancers within their organ of origin, is a multinodular internal appearance. And this results from variable dedifferentiation of different components. So different parts of this hepatocellular cancer will look different because they are histologically different. So we have the hyperenhancement, and the delayed image shows the washout, and in fact multiple capsules. So no doubt about this diagnosis. What's the best management? Given its vascularity and the solitary nature, chemoembolization is a high likelihood, but perhaps ablation will also be considered. So here is a mass that would qualify for LI-RADS 3. Now, if we just look at that top right, we see some hyperenhancement way at the periphery of the liver. And if this was the only image that showed it, we may consider giving it LI-RADS 2 for arterial portal shunt. But hopefully this projects well enough on your computer, but if you look at the image on the left, this is the T1 weighted unenhanced image. There's some slight hypointensity, which I find a very useful feature for bumping from LI-RADS 2 to 3. Perhaps it should have been called an ancillary feature, but there were reasons it wasn't. And it's persisting a bit on the late post-contrast. So a key thing when you see hyperenhancement, especially at the periphery of the liver, does it look like a lesion or a pseudo-lesion, or a nodule or a pseudo-nodule? And this indeed looks like something is there, and that's why it was called LI-RADS 3. Notice for convenience, it's right next to a cyst. So this is going to help co-register the images on subsequent imaging. And in fact, as it turns out, 7 years later, now I can assure you, we didn't recommend this should be followed up in 7 years. But that's in fact what happened. The patient disappeared for a while, came back, but fortunately, it's still not out of control. But now it's definitely hepatocellular cancer. It's hyperenhancing with washout. There's probably a little bit of arterial portal, or a little bit of perilesional delayed enhancement. Notice on the T2 weighted image to the right, you can see it's right next to that cyst, so we're definitely looking at the same thing. Moderately intense on the T2 weighted image. Doesn't have threshold growth because it's been 7 years, so we don't know if it grew fast enough, but we're still sure it's hepatocellular cancer. Goes to multidisciplinary management, and that's where the decisions get made. So now we'll look at another LI-RADS 5. So this is also definitely hepatocellular cancer. No difficulty seeing that it's hypointense on T1, hyperenhancing, perhaps also a mosaic configuration with very clear washout, so hepatocellular cancer. But the shape looks a bit concerning. It seems to have indistinct edges as you get toward the porta hepatis. I think there's legitimate concern that there could be tumor in vein. So we looked at this, we looked up and down throughout the images, but we just were not sure if it's tumor in vein. And that's why it was not categorized as tumor in vein. It's categorized as LI-RADS 5, because you don't call it LI-RADS TIV unless you're sure there's tumor in vein, and we weren't. But we're still very concerned. So this gets discussed in the multidisciplinary management conference. The patient is still a candidate for transplant, but there is concern that because if there is tumor in vein, patient's prognosis wouldn't be as good. So should we get short-term repeat or alternative imaging, maybe fine-tune the protocol to look to see if there's definitely tumor in vein, or perhaps contrast-enhanced ultrasound? But that gets discussed. So just because it's LI-RADS 5, it could still go in different directions depending on what else you're seeing on the imaging study. Here, in contrast, there's no doubt about this one. This is tumor in vein. We called it LI-RADS TIV, not a transplant candidate, but there are treatment options. Given the hyper-enhancement and the washout, I think we have a high confidence that it's hepatocellular cancer. So here's a lesion, and you can see some subtle hypointensity on the T1 weighted image, pre-contrast, top left. And I should mention, don't get faked out by the hyper-intense aorta on the pre-contrast image. That's a time of flight effect, inflow enhancement from above. So just always be aware of that. So if we go to the middle image where we have measurement, we see hyper-enhancement, and the bottom right, we see washout. And I will admit that this was categorized as LI-RADS 5, but I think some of you realize, whoa, that shouldn't be, it's targetoid. So indeed, it's most appropriate to be on the lookout for targetoid and other features for LI-RADS M, because this has different management implications. Rather than go straight to treatment for hepatocellular cancer, indeed, this went to biopsy and was cholangiocarcinoma. So we'll shift now to the post-treatment categories. And we've had really 1.5 outstanding lectures on treatment. The other half is going to be reprised later because of the hacker. But in any event, it's a 3-point confidence scale rather than a 5-point confidence scale. And this was a deliberate decision. 5-point confidence scale applies to situations where there's different implications between probable versus definite. But when somebody is short-term post-treatment and is getting post-treatment surveillance, there isn't a realistic difference between probable or definite viable tumor versus probable or definite non-viable. In fact, we're never sure that there's no viable tumor. So it would be meaningless to have a LI-RADS 1 and 2 equivalent. So in any event, we have these 3 categories. LI-RADS TR viable is when it's very clear that there's viable tumor. Arterial hyperenhancement, washout, typical appearance. Equivocal, there may be some enhancement within or adjacent or at the edge of the tumor that might be viable tumor, but then again might be reactive change. In practice, it seems the majority of the TR equivocal cases are indeed viable tumor. And as we learn more about this and refine our criteria, this will have management implications. But importantly, these patients are generally going to be getting repeat imaging rather quickly. They're not in long-term surveillance mode because there could be tumor beyond our resolution that may declare itself soon. So we'll look at some examples. So this is an example that's rather straightforward. In the old days, we would look at the February 11th post-treatment exam and see a lesion, we'd measure it, and April 8th, we would say the lesion is smaller, consistent with treatment. But a more sophisticated approach, which we're accustomed to now, is to recognize that the necrotic portion of the tumor, the fact that that shrinks, that doesn't tell us anything. It's worth mentioning it for descriptive detail, but the important thing is there viable tumor? The answer is yes. And how does that viable tumor look between the two exams? Now the shape is a little different because the necrotic portion is retracted, but there's no way you would say that the viable tumor has gotten smaller. In fact, it may even be bigger. To actually measure the one dimension that's by definition how you report it, it's probably similar, but I think April 8th, it looks a little bit thicker. So in all likelihood, the viable tumor is growing. So this really should get treated. This case is a bit more challenging. So the patient previously had a LI-RADS 5, definite hepatocellular cancer. I'm pointing to it here, ovoid, well circumscribed. It was hyperenhancing with washout, and then received chemoembolization. And we have some severe atrophy of the rest of the affected part of the liver. And here is the mass. So we have this markedly increased enhancement of the damaged liver because the portal vein had subsegmental portal vein occlusion secondary to treatment. This happens to be a nearby cyst. You might be tempted to think, well, post-treatment, no enhancement, TR non-viable, but don't go that route. You need to look very carefully. I have a subtraction image here, but I try to urge people not to rely too much on subtraction. In fact, you might think this is an enhancing additional nodule, but it isn't. It's misregistration artifact related to the cyst. So even though we've tried to register the images, the left lobe and the right lobe may not register the same. Down the road, we'll probably have more sophisticated versions of co-registering a soft deformable organ, but I think it's very important to look at the source images. Very strongly hypo-intense compared to background liver. Now it's just about iso-intense. So there should be no doubt that this is a mass that has enhanced more than background liver. Now, if this was an untreated observation, you might not want to call it hyperenhancement, but perhaps if you're really confident it's tumor, you could convince yourself that these little nodules within it are indeed hyperenhancing. In fact, notice the morphology of the lesion changes. What's now brighter within the enhancing tumor was darker pre-contrast. And that's another sign of internal enhancement. The morphology changes because there is incomplete necrosis here. So something like this, some people would say, well, there is some enhancement, but it's not hyper-enhancing. Let's call it equivocal. But I would urge you to call it viable. And just to be technically on the hyper-enhancement side, you could convince yourself of these little nodules, whether or not the subtraction enters into it. But the important thing is this is the mass. We know from looking at it before, this is the mass. And inside the mass, we have living tissue. If it was not alive, it wouldn't enhance. So we have living tissue inside a mass. And I don't see how not to call that viable. We did a small series at our institution where we looked at our false negatives. That is, we had patients who had local regional treatment and then went on to explant, and we isolated the case where there was viable tumor that we didn't see, and invariably it was because of incomplete necrosis. And when a pathologist says incomplete necrosis, that is often not a glob of tumor and a glob of necrosis, but microscopically, necrotic tumor with islands of viable tumor. And those will show mild enhancement increasing over time. In any event, angiographically confirm the tumor, repeat chemoembolization, and patient did well. So the final subject is liver transplant, an important method of treating advanced liver disease, but also treating hepatocellular cancer. So we need to keep two important points in mind. One is that transplant candidates will get tumor exception or priority points for hepatocellular cancer greater than 2. So maybe they have significant liver disease, but not as advanced as someone else. But if they have a tumor greater than 2 centimeters, a definite tumor, then they get bumped higher up in the list. So you could almost think of it as the tumor helping the patient get the transplant they need. But then there's the Milan criteria. So it would be too much of something. I wouldn't want to say too much of a good thing, but too much of what would get them the priority may push them too far so they can't qualify for transplant. So they're within Milan criteria if they have 1 hepatocellular cancer less than 5 centimeters, or 3 or less, all of which are less than 3 centimeters, and no macroscopic tumor in the vein. So the state of the art back about 10 years ago, the American Association for the Study of Liver Disease, the AASLD, had recognized the importance and the possibility of using imaging to diagnose hepatocellular cancer, and in fact provided data confirming that this was a viable way of diagnosing hepatocellular cancer, avoiding biopsy. But then UNOS had realized that too many patients were getting priority points, and in fact many of them didn't even have hepatocellular cancer. So they recognized that diagnostic imaging needed to improve and needed to be more standardized, and in fact developed a standardized scale to do that. And this was essentially done concurrent with, as LI-RADS was being developed, UNOS developed something similar but not quite identical. So over the years, again, the AASLD had already defined hyperenhancement with washout greater than 1 centimeter as being diagnostic of HCC. OPTN incorporated that in a specific scale that they adopted. And then LI-RADS, composed of a large number of liver imaging experts, felt that we needed to define this more precisely. What exactly are these criteria? What is the best data? And how do we build the best possible system? And over the years, the AASLD and the LI-RADS team have been communicating, and essentially we're now totally on the same page. LI-RADS 2018 included some modification to bring LI-RADS and the AASLD in complete concordance, and these apply to all at-risk patients. But OPTN, rather UNOS, has a different mission, and the OPTN scale applies only to potential transplant candidates. I think the goal will still be for LI-RADS to provide a robust and precise description, and those descriptors can be utilized by UNOS to allocate transplant, obviating the need for a separate scale, which is almost identical but not quite. So at this point, we need to recognize that LI-RADS and OPTN are not exactly the same. We need to remember that OPTN staging derives only from the LI-RADS 5 greater than 2 centimeters, LI-RADS TIV, path-proven HCC, or TR viable. So in other words, a LI-RADS 5 less than 2 centimeters doesn't contribute to OPTN staging. Now that's not a fatal flaw. UNOS could allocate transplants only to HCCs or only to LI-RADS 5 greater than 2 centimeters. So I think ultimately we'll be able to use LI-RADS for everything, but we're not there yet. And in fact, there's a particular carve-out where LI-RADS 5 and OPTN 5 differ. And this is because capsule and washout, and as well as threshold growth, are considered major features, but the AASLD has always emphasized washout as a more important major feature. And in fact, LIRADS 2018 does the same. So an HCC with arterial phase hyperenhancement and washout, but no other major feature, is AASLD positive for HCC and LIRADS 5 as of 2018. But this is still not OPTN 5, so capsule becomes an important part of it. It's one little scenario, but be aware that they're not identical. So in conclusion, LIRADS categories convey image-based likelihood of hepatocellular cancer, but other diagnostic data can affect these probabilities. And the probability of HCC by itself does not determine management. Multidisciplinary discussion includes comorbidities, transplant candidacy, and other factors. Thank you for your attention. It's the sound of one hand clapping.
Yeah, thank you very much, Dr. Mitchell. Actually, I was clapping, but I was muted. I found out that I was muted. So that was a great lecture. Thank you very much. We really all appreciate that. So